Good evening, everybody. I'm Dr. Anuradha Sekaran, pathologist AIG Hospitals. At the outset, I would like to thank Dr. Sanjay for inviting me here today. I've been asked to talk about rows and ancillary techniques and a little bit about IHC. As I was just discussing, I know that most of the major centers have shifted to FNB, but still there are some centers which do not do FNB, and so how to get the maximum yield of the precious material is the question, because after doing an exhaustive procedure, you don't want to get a report which is inadequate. So I would like to talk about the pre-analytic variables, which are very important, wherein how you have to retrieve the maximum material of the aspirate, and what are all the tests which you can do based on the diagnosis which you get in the endoscopic suite if you have the benefit of having a pathologist for on-site evaluation. So of course there have been various studies which have shown that rapid on-site evaluation will definitely help in decreasing the non-diagnostic samples, and this could be due to various reasons. Either the tissue is showing a lot of desmoplasia, so you're not getting good cellularity, or you've got a good aspirate but you have not made smears in time and so it is all obscured, or there are a lot of crush artifacts. It also depends on the number of, reduces the number of passes, reduces patient discomfort, complications, and of course cost to the healthcare system. So the most important step is that as soon as you get an FNA, the important steps that is you have to make an immediate smear and not even delay by a few seconds, because it is going to clot and then the entire procedure goes waste. And also it depends whether you are going to use a stillet material or you are going to use air-filled syringe. A stillet material is where you'll drop it drop by drop and make smears, which is best, and not use an air-filled syringe because it leads to scattering and loss of material. And the important thing which you have to realize is if you make very thick smears, there is good material but which is all obscured in the because of the clotting, and you are not able to interpret the smears. And then how many slides should you make per pass? So it is recommended, and also at a study at AIG hospitals we have seen that only the first 2 drops contain maximum material and they have less of blood. So just make 2 slides per pass and put the rest into the formalin container. And also how many number of slides to make and how to fix the slides. So in practice you can make air dried smears and you can make fixative smears. So fix one in the isopropyl alcohol 95% and the other you can take it for air dried. And also you should realize that irrespective of the type of needle you use or the method, any material you get is diagnostic. Because for example, in the serous cyst adenomas, you can get a clear aspirate. So that does not mean it is not representative of the lesion. So you have to know what the background case is. For example, if you have lot of debris and cyst macrophages, that means you're dealing with a pseudocyst. So the material which you get is also very important. And MOSE, that is the macroscopic on-site evaluation. So today morning also when we did a case, we have seen that when you make smears and you have the thin granular material which you can visualize on the smear even without staining, you know that there is some amount of material. And if it is mucoid, it gives you an idea that probably you're dealing with a mucinous neoplasm, or probably it is mucinous contaminants, and this will depend on what type of approach you are going for your EUS, whether it is transduodenal or transgastric. So maybe you have to hit the contaminants. If there's a lot of necrosis, it could mean that either you're dealing with infective or malignancy. If it is hemorrhagic, metastatic tumors also can cause a lot of hemorrhage. And cyst fluid, as we said, it can be clear, watery or serous, which will give a clue about the type of lesion. And also as soon as you get some core of material which clots like this, the best way to get good material is to place the material on a slide and try to separate the white cores from the red cores. At a study at AIG hospitals, we have found that when we have tried to separate the white from the red cores, the white cores gave us more material, so it was maintaining the architectural details. So you are able to interpret the biopsy material much more rather than the artifacts of the blood contaminating it. And so you isolate the white core like materials and put it in one container which is 10% formalin, and also take the hemorrhagic aspirate into another container and make a cell block of it. And next, about the number of slides. So just make 2 slides per pass. And you can do the different kinds of either PAP or Romanowski steams. At our center, we use the rapid H&D. You can also use the rapid DiffQuick for on-site evaluation. And as I said, not more than 2 to 3 slides. And then the rest of the material should be dropped into formalin. This will help you to optimally utilize the material. So what is that which you get in your formalin container? That is, you are going to make a cell block of it. And also for optimally retrieving the material, rinse the needle aspirates into the formalin container, and you can process it and you can make the pellet, and this will act like a tissue biopsy on which you can also do all your ancillary techniques. And also when you have the liquid cytology, you can also use the liquid cytology containers which will break the mucus, and so it will give you much more better background of the slides. And also if the endoscopist is doing FNA from 2 to 3 different sites, it's better that you collect all of it in separate containers. For example, if you are aspirating a pancreas and a lymph node, the main idea is you want to know if you have a metastatic lymph node. You don't want to mix up both the materials in the same container, because then you won't know whether you're dealing with a primary lesion or if the node has a metastasis. So always collect it in different containers. And then what are all the ancillary studies which you can do? So on your cell blocks or FNBs, you can do immunohistochemistry, and you can do molecular studies, like for example, the KRAS, the PDL1, the MSI can all be done on these. And also when you give a diagnosis of COX at on-site evaluation, you can collect sample for PCR. And you can, if you have a lymphoma, you can collect the sample in isotonic saline for your flow cytometry. Also the cell block and FNB are materials on which you can do your FISH analysis. For microbiology samples, collect a separate container in the culture bottle. And if you are suspecting anything which needs electron microscopy, a separate sample has to be collected in glutaraldehyde fixator. So we have also, Dr. Neetu has said that you should follow any one standard method of reporting so that you are on the same page as your endoscopist. Because when we give a diagnosis of atypical versus neoplastic, it is quite different. For example, in the PAP stain, when we say neoplastic benign, it means your neuroendocrine tumors, the SPEN and the other lesions. And when we say suspicious, that means it is paucicellular, but they are atypical cells. And so you are not able to rule out malignancy, but the pathologist is not having much material to confidently label it off as malignant. And this is particularly seen in case of the pancreatic lesions when there's a suspicion of doubt. And the pathologist should also know what is normal from abnormal. So I won't go into the details of normal, but also the pathologist has to remember that they can be contaminants, so do not overinterpret this as lesional cells. So you can get mesothelial cells, you can get hepatocytes, you can get intestinal contaminants which can be a colonic or duodenal mucosa, which you can identify by the presence of goblet cells and the mucinous cells. So these are the pitfalls which are very important, which can affect your reporting. And also when you get of late endoscopists are doing EUS guided liver biopsies and FNAs. So when you get a long core, sometimes the endoscopist feels I've given a very long core. So all this thing is not liver tissue. So as soon as you get this core, collect it in a petri dish and flush it with some saline, and then try to separate the white cores from the hemorrhagic cores right at the endoscopic suite. You can use the 5 cc syringe needle and try to separate the white cores to finely dissect it so that you don't break it. So if you see the one in the circle, that is your actual tissue. So separate all the cores and then collect it in a separate container, and then pick up the white cores. And you can place it on the slide, and then you can put it in the in the cassette for fixation. So this is actually the liver course and not the entire course which you have seen. So, and if you don't have a pathologist on site, an endoscopist or a nurse or a technician can be trained. And of course, FNB has much more value. So I'll just show one case of pancreas wherein IHC also plays an important role. This is a 54-year-old male with a 3 centimeter lesion in the pancreas abutting the portal vein. So FNA, from this slide, if you get good material like this with disordered sheets and clusters, we definitely know that we are dealing with a neoplastic lesion, but the pathologist may not be able to sign it out as a pancreatic carcinoma if the amount of material is not good. But if you have a cell block, like this, it shows the good infiltration of the lesion into the stromal tissue. So with this, we can definitely give a diagnosis of pancreatic adenocarcinoma, or you can use ancillary tests like IHC for pancreas, like IMP3, SN100P and MASPIN, which are positive in adenocarcinomas, and SMAD4 is negative, and SMAD4 is positive in the benign cells. Sometimes it can be so paucicellular like this that in the last figure, if you see, if you have a good core, you can confidently give, and this is the foamy gland cell pattern of the pancreatic adenocarcinomas. Another case where patient is a female with elevated amylase and lipase and had a pancreatic head mass with sausage shaped pancreas with biliary stricture, and FNA was negative, showing benign ductal cells and lot of inflammation, but we have to pay attention to the inflammatory infiltrate as well. In the same time, patient also had a brush cytology from the CBD structure, and it also was negative with lot of plasma cells. So with this, we should keep in mind the diagnosis of IgG4 related disease, and an IHC can be done, which is positive here, and patient responded to steroids. This is another case of a patient with heterogeneous SOLs in head and body of pancreas. FNA was cellular, monomorphic round cells, sized of neuroendocrine tumors, but for neuroendocrine tumors, we need to confirm with IHC, and we need to grade it by doing Ki67, because we know that higher the grade, poorer the prognosis, and according to the WHO classification, though we count the number of mitosis, since there's lot of inter and intra-observer variation, and IHC with Ki67 is better. This is another patient which is 59 years with a mass in body and tail of pancreas of 8 centimeter lesion, and on FNA you can see spindle cells. So this can only be signed out at the time of EUS FNA as positive for neoplastic and some mesenchymal tumor. But if you get a cell block, then we can do IHC, and in this case we have done Desmin, that is the mesenchymal markers, Cal-Desmin, SMA. So it was a leiomyoma, and Ki was very high, around 30%. So definitely it's not a benign lesion with a size of 8 centimeter and high Ki67. It's a leiomyosarcoma. This is another 62-year-old male with CT showing multiple lymph nodes, and there was narrowing of CBD on spyglass. This is a brush cytology, and if you see, it was very cellular, and this was given as a atypical lymphoid cells, and we had a biopsy from the lymph node, and we did a panel of IHC. Bone marrow was also positive, flow was also done, and this was a non-Hodgkin's lymphoproliferative lesion of T cell type infiltrating into the bone marrow as well. So I would like to conclude by saying that the role of the pathologist at on-site is not only to give a diagnosis, but also to help the clinician in optimally preparing the smears and not wasting the material which has been obtained, and also to give suggestions to the clinician as to what additional tests can be done. And today, in the era of precision medicine, we need to collect material for NGS, so you need to have at least 2000 cells. So you need to have a good cell block or a core biopsy for using immunomodulators like PDL1, where you need to do IHC. Thank you.